Hi, everyone. My name is Jace Terry, and I use they, them pronouns. I am a white, non-binary person with shoulder-length brown hair, and I'm currently wearing a black sweater. I'm a graduate student in clinical mental health counseling at San Francisco State University, and I'm also a peer support specialist.
I'm Julie Chronister, pronouns she, her. I'm a white cisgender woman, and I today have my hair, light brown hair pulled back, and I'm wearing black rimmed glasses and a black t-shirt, and I'm in my kitchen with a white background. I am a faculty member in San Francisco State University in the Department of Counseling, and I've been a counselor educator since 2004. Welcome.
Good morning, everybody. My name is Sandra Fitzgerald. I am an Asian American woman. I use she, her pronouns. I am sitting in my office and with a window behind me. I am I have long brown hair, black rimmed glasses, and I'm wearing a red sweater. I am also a faculty member at San Francisco State University, and I'm really happy that you're all here.
I'm going to read I'm going to just mute someone first, but I'm going to read our land acknowledgement now. The Department of Counseling at San Francisco State University, which is where we're located, is located on occupied Ramaytush Ohlone and coastal Miwok land, who along with the Southern Pomo are organized as the Federated Indians of Grattan Rancheria. We express our deep gratitude to the indigenous peoples who have cared for this land, as well as those who are currently striving for justice and land rematriation for indigenous communities. We encourage you to learn whose land you are on if you live in occupied territory and support local indigenous-led efforts for justice and land rematriation. For example, if you live in the Bay Area, consider paying Shumi land tax to the Sogorea Te Land Trust, which rematriates land to indigenous stewardship. And I'm going to share a few links in the chat if you're interested in learning more.
So my colleague just let me know that there was an audio issue. So if anyone asked me any questions earlier, I'm so sorry. I did not hear them. I think it is fixed now. With that said, I'm really glad that everyone is here. And now that we've kind of had an opportunity to introduce ourselves, we'd love to get to know you as well. So if you wouldn't mind in the chat, if you could please just share your name, your pronouns, what brought you here, and where you're currently located, that would be great. Also, I'm seeing in the chat, someone can't hear. Can y'all hear me now? Okay.
Are you asking us to introduce ourselves verbally?
In the chat, please.
Oh, in the chat. Okay.
Thanks. Thank you for asking.
So I am going to go over today's plan in our next hour and 15 minutes together. Also, I wanted to let you know, after you introduce yourselves and use the chat function for this purpose and to network, we are going to ask that all questions and major comments be left to the end of the presentation. We will reserve some time for feedback and discussion. So if you could reserve those questions. If you would like to use the chat to network, provide some responses, short responses in the chat, we will be monitoring that, or if there's any other issues that come up. But if you could reserve your major questions and feedback till the end, that would be great. So today's plan is to share with you our study aim, the rationale, our methodology. The results is kind of the meat of this, our additional findings, limitations, and then our discussion. So the primary aim of this study was to identify peer support advanced training competencies. So we know that peer support specialist is a growing profession, and there's lots of professionalization and certification going on. And so we were interested in what other training competency and skill areas are peer support specialists interested in. So that is the aim of the study.
Yeah, so Dr. Fitzgerald was beginning to talk about the rationale, and as probably many of you know, Peer support is one of the fastest growing professions in the behavioral health workforce. And there has been an increasing interest, both from those in the field, both who spend time writing and researching about peer support, that we need to better understand what the current training needs are and what the training gaps are. This is not unlike any other profession, where as we move along, things begin to be more clear about what we're missing, what roles and functions we need to train our students and peers around. There is often a concern about role confusion amongst our peers. There's also a growing trend of specialization areas and continuing education. So we were particularly interested in understanding what else needs to be taught at a more advanced level above and beyond the certification course. And so that's the primary reason why we're doing this study. So I'm going to review our methodology, how we approached this study, what was our design, who were our participants, how did we gather the data, the information, and how did we actually execute this, and what was our analytic process. We used a qualitative descriptive design. For those of you familiar with qualitative analyses, we're gathering a lot of textual and transcribed data, and we're coding and organizing and cross-analyzing and trying to determine some overarching themes. So we followed Kim et al. And Sandalowski's method. In brief, we used focus groups, individual interviews, we used a Qualtrics survey, and we also reviewed the literature. So we're proud of our sort of triangulation approach in terms of gathering data from different methods. We conducted 4 focus groups with a total of 35 participants. We had 2 individual interviews with 2 participants. We sent out Qualtrics survey to numerous individuals. We actually had a large response to our Qualtrics survey, over 500, only to come to realize that we ran into a lot of AI issues. Those of you who are doing Qualtrics surveys or surveys that way, be aware. Ultimately, we had 119 surveys that were valid, that were included. We also combed through the literature. We had probably, I think, around 70 articles to begin with, and we ultimately reviewed 32. What did we use to gather the data? Well, we sent out a background demographic survey. Everyone who participated in our study, whether they actually completed an online survey, attended a focus group, did an individual interview, all were asked to provide us some background information about who they are so we could describe our participants. For our focus group and individual interviews, we had a question script where we asked specific standardized questions to get at our research focus. We also used the same question scripts in the survey. So in the focus groups and interviews, the data was transcribed. In the survey, the data came through as text. And so we analyzed the textual data. Just briefly about background, and I will review the results of the background information, but we were interested in, what have our participants been trained in? What courses? Are they mostly certified? How did they perceive their training preparedness? Were they supervisors? If so, or if not, how do they perceive the quality of their supervision? What were their lived mental health experiences? And, we also asked some background demographic information aligned with most research studies related to age and gender, race, relationship, education, geography. We also asked about disability and veteran status. The questions that we ask across the board to all of our participants, irrespective of how they were participating. Those that were peer specialists, we asked these 5 questions. What advanced training areas do you think need to be taught? What competencies taught in your initial class would you like continued training on? Conversely, are there areas you learned that you feel you don't need more training on? Can you describe a time when you felt you were unable to help a peer, and what knowledge or skills would have been helpful for you? And then, are there any additional thoughts that come to mind? We finally asked people to review our Medi-Cal core competencies and to identify things they thought were relevant and irrelevant. What would they keep? What would they not keep? Similarly, we tailored this script slightly differently to our trainers. So we asked more specifically, what areas do you think need to be taught? If, what topic areas taught in the certification course do you think needs to be taught in the advanced course? Describe a time when a student shared that they were unable to help a peer due to lacking knowledge. And then again, any additional thoughts and their thoughts around Medi-Cal core competencies. So I just wanted to clarify again, and I'm not sure if I did this, but it's important to know that not only did we gather data from focus groups, individual interviews, and survey, but we gathered it from peer support specialists, working peer support specialists, as well as peer support trainers, as well as peer support students. So I want to make sure that was clear as well. Our procedures, like many research studies, we were approved by San Francisco State University for human subjects and ethics approval. In terms of recruitment, we used what we call a purposive sample, meaning we knew specifically who we wanted to participate. And so we sought out those individuals. We used LinkedIn, and we also used the California peer support. We reached out to California peer support training providers. We collected this data in the fall of 2023. And eligibility needed to be 18 and older, understand English, be a certified peer support specialist, trainee, or trainer. Again, we collected our data through literature, the focus groups, and individual interviews and Qualtrics survey. Okay, I will pass this over to my colleague.
Okay, so for the data analysis there, it was qualitative research, as Dr. Chronister just explained. So during the analysis, we used what is called qualitative content analysis. So we're really looking at during our analysis, we're trying to develop themes and categories. That was at the core of our analysis. And we used the inductive method. So what we did was we looked at the textual data from the surveys, but we also transcribed. We used a service called Otter AI and automatically transcribed our focus groups and individual interviews. And so we had a coding protocol that the research team, the 4 of us here represented, abided by. And so what happened was we had the transcriptions, and individually, separately, we would use the protocol to code the data, to look at themes and major categories that were coming up. And then we would come together as a team and do a process, which I'll show on the next screen in a minute. And we would look at patterns to see if there was some consensus among the individual team members of categories and themes that were coming up, which we'll share in the results. So we did this thematic analysis, and we used a pretty fun method called the Jamboard. It looks like a mess here initially, but what these are these little sticky notes that you can move around. So initially we would come together as a team and would meet as a team during our meetings. And so we would each take a color of a sticky and work on one side of the board, identifying the themes that we found independently. And then we would put these on the board and then come together as a team and try to see if we have some consensus as a team. So we would move these stickies around, they move around, they're kind of fun. And then we would try to cluster them together with similar categories and themes. So this is probably just based on one set of data. So we have multiple Jamboards that we looked at, and then we will be sharing the results of that thematic analysis a little bit later.
So one of the important things about qualitative research, different from quantitative research, is really what methods are we using to try to ensure that our findings are in fact credible, reliable, dependable, actually are to some degree valid. And qualitative research is unique in that there's a lot of things contributing to how data and themes are determined. But some of the ways in which we sort of aspired towards what we call trustworthiness is we had 4 independent coders. 2 of us are faculty members and 2 of us are students. And we also had 1 certified peer specialist amongst our research team. So 4 different perspectives. We also had, as I mentioned earlier, 4 different approaches to data collection, which in the world of qualitative research really speaks to what we call triangulating, or a form of ensuring credibility. The idea being that if we're getting things from different approaches, different avenues, we are more likely to have a sense of reliability in the data. We also had 3 participant sources, as I mentioned. We had certified peer support specialists, we had peer support students, and we had peer support trainers. Participant checks we did while we were running the focus groups. In other words, probing, reflecting, asking for clarification, making sure that we understood what they were saying. And we were also quite vigilant around making sure that our transcriptions, as they were transcribed by an AI method, were in fact aligned with what our participants said. And finally, we did have standardized inquiries and process those question scripts. We would deviate at times as needed, but we did stick fairly well to our standardized questions. Okay, so our results is obviously the most important part of this study. And we're going to provide an overview. First, I'll give you a brief overview about who our participants were, and a little bit about our literature sources, and then we'll dive into the most meaningful aspect of this presentation, our themes. So this is these are a general description for those of you who are interested in the details of our participants. I am happy to send along tables with all the gory details of participant description, but I thought the best was for this presentation would be to summarize. So the majority of our participants across the board, whether they were in focus groups, interviews, or surveys, were between the ages of 30 and 50. I understand that's a wide span, but I can tell you the younger side of our participants were those that completed the online survey, and the older side of our participants were our trainers participating in our focus groups and individual interviews. Our participants were not surprisingly mostly cisgender, mostly white, although our focus group participants were significantly more diverse. And I can speak to that. Our focus group participants were mostly from the Bay Area. And so we did have more diversity there. Most of our participants also had some level of college education, were either single or married or partnered, and most lived in an urban environment. We did ask about disability and veteran status. The majority of our participants were mostly non-disabled. However, our trainers were mostly identified as disabled. I think across all of our participants, we might have only had one who identified as a veteran. In terms of lived mental health conditions, our participants reported to have on average 3 mental health conditions, with mood, trauma, and neurodiversity related conditions the most common. About 45% of our participants reported having received peer support services in their past. We did ask them if they were satisfied or what they thought about that. Very few answered that question, but the few that did appeared to be quite satisfied, but it was a very limited number of textual responses. Sorry, that next bullet point I've already stated. This is a slide that's been repeated. My apologies. The bottom bullet point is new. Most participants had taken 2 to 3 peer support courses prior to participating, and approximately 2/3 had completed state certification courses, or somewhere between 25 to 50% had actually taken an advanced course. Most participants had been certified for at least 1 to 3 years. However, the majority of focus group participants had been certified for 6 to 8 years. Participants who were employed as peer support specialists worked mostly full or part-time, and about half our participants reported having either been a supervisor or were supervising a peer support specialist. Finally, we did ask one question about their perceived preparedness and their perception of the quality of the supervision that they had received. Now, granted, the supervision question for those either that weren't currently working may not have answered this, but the majority of our participants who were asked these questions did answer them. And again, this is one question, so this is not a valid measure of preparedness. However, we did ask, using this Likert scale or Likert type scale, how prepared do you think you are for the peer support workforce using this scale of not prepared, adequately prepared, well prepared, very well prepared? And for that, we had an average of 2.7. So somewhere between adequately and well prepared, not bad, and a small spread. So that seems, relatively reasonable. For those, when we asked them about their perceived supervision quality that they were receiving, on a scale of 1 to 5, with 5 being excellent and 1 being poor, we got an average score of 3.9. So again, more on the positive side with a little bit larger spread. I just wanted to give you a few details about our trainers. And I mentioned this earlier, but just a brief overview that our average trainer was about 49 years old, mostly cisgender women. Half were Black or African American and half were white. Trainers were mostly state certified with the exception of one who was a certified rehab counselor. Our trainers were from California, Illinois, South Carolina, and New York. And all were employed at peer specialist training programs with the exception of one who was self-employed. They all reported teaching a variety of courses, including the certification course, an advanced level course, workshop, continuing ed courses, and in fact, several of them were teaching some of the specialization courses. So in terms of our literature, I'm just going to share briefly that we started with about 73. I might be off a bit. We started with about 73 scholarly articles. This was actually our first step. We dove into the research. We used various search terms. I'm sure I don't have them all up there. whether it was peer support, peer specialist, peer counseling, peer support training, peer specialist training, curriculum, a variety of different search terms. We searched the all term on the databases. So on our library system here at San Francisco State, you can click all, so it reaches all of our databases. We reviewed qualitative articles, quantitative meta-analyses, systematic reviews, and concept papers. We sort of narrowed it down to about 41 articles. I think there were like 41 articles or something around that, just that appeared to be unrelated to our study. I will say, it was hard to determine which ones were relevant because the peer support literature is just rich with so much information, and there's so many emerging articles. So much of it was quite helpful, but really finding articles about training was much more limited. And so we ended up probably using data from about 30 articles. Okay, I'm going to pass this over.
Thank you. So through our coding process, we reached consensus on 8 advanced training themes. Our themes were fidelity to the peer support model, advocacy, self-care, crisis support, relational competencies, recovery support skills, supporting specific communities, and substance use and harm reduction. So now we're going to dive into more details about each of these themes. So the first theme is fidelity to the peer support model. We're defining the peer support model here as the values, ethics, philosophy, and approach that make up peer support, and defining fidelity as adherence to or integrity to that model. Next slide. Advanced training themes in fidelity to the peer support model could include reviewing the recovery model and recovery language, role clarity, which involves understanding the peer support role, what it is and what it's not, and understanding the scope of practice of a peer support specialist, both in terms of ethical and legal standards and in terms of scope in a specific workplace role. For example, some peer support specialists work on mobile crisis teams and often provide direct crisis support. In contrast, in other peer support roles, the peer may be asked to immediately refer out to a clinician or hotline in a crisis situation. Mutuality refers to how peer specialists strive to be non-directive and non-hierarchical in their relationships with peers. They share power with the peers they serve and don't exercise power over them. Advanced training in mutuality could include learning how to resist the impulse to try to save or fix peers. Instead, peer specialists respect the self-determination of peers and value the wisdom of their lived experience. Ethics involves reviewing peer support ethics. Many participants expressed a need for more training around establishing boundaries between the peer specialist and the peers they serve. And then it can be challenging for peer support specialists to maintain fidelity when collaborating with interdisciplinary teams and facing workplace pressure to change. And there's some crossover with the advocacy theme here. So advanced training in this area could involve building advocacy skills to support actions aligned with the peer support model. For example, peer specialists could advocate for interdisciplinary teams to use recovery language rather than stigmatizing language, or engage in self-advocacy when a supervisor asks them to do something that is not aligned with the peer support model. Next slide. So I'm going to read a quote here from one of our participants. This was a participant in the peer specialist trainer focus group. Peer, by definition, is mutual. That's what the word means. It's a relationship term. None of us, by identity, is a peer. We are in peer relationships. It's really easy to assign people to do non-mutual work in their job because we've forgotten or left behind or ignored or co-opted the meaning of that word. Next slide. And I have another quote here from a participant in one of our trainer focus groups. To me, a peer specialist is a specific job that is a relationship job based on mutuality and shared lived experience. Next slide.
Okay, so I'm going to talk about our next theme, advocacy. Advocacy training or advanced training in advocacy, as described in our study, includes learning in more depth about how to advocate for increased access to people, supports, and systems by reducing attitudinal and power-related barriers that impact both the peer support specialist and the individual receiving peer support. Advanced advocacy competencies are applied on behalf of or in collaboration with a peer, or involve fostering a peer's self-advocacy and empowerment through the peer-to-peer relationship. Advanced advocacy training also involves learning strategies and actions to advocate for peer support work to be aligned with peer support principles and values. So as you all are probably quite familiar, the term advocacy is a large, broad construct. And I think what we believe is most important is to figure out at an advanced level what, in fact, are the advocacy skills, knowledge, and attitudinal areas that are really important to dive into further. And I think advocacy is important in terms of fostering self-advocacy amongst the peer to which the peer support specialist is working with. Indeed, at the same token, we heard a lot about advocacy out in work environments where peer supports need to advocate for their profession, their roles, their functions, being able to articulate their model or understand or conceptualize what's going on in these environments through the lens of the peer support model. So I'm going to show you a couple quotes. I think there should be advanced trainings of how peers work in the system and how the advocacy around how peers can try to make sure that they're working in a system that aligns with them ethically and aligns with them and their values, and their lived experience is valued. This was a common sentiment that we are out in a health or mental health system, and our beliefs and philosophies are often misaligned with the medical model approach. And so how do we advocate not only for our own individual roles and functions, but also for our larger profession within a context that is still trying to wrap their head around the recovery and the peer support model? Another quote, like, how do you advocate more on like a systems level? How do you like help people address stigma and self-stigma? And like, how do you address stigma and like within communities? We don't have a lot of time for that in our regular, curriculum. Yeah, I see that as a more advanced skill. And finally, quote, I was kind of going to say just in ways to support clients in self-advocacy, I think is a big thing. And they definitely talk about that so much. Maybe sort of teaching peer skills and how to work with outside colleagues. So people like third-party colleagues, with clinicians, or with, and sort of like, I think it could be helpful to sort of teach peers how to navigate those situations with clinicians, or if they are put into that situation, could be beneficial. Just in that very niche of sort of accompanying people. Just want to say that it would be helpful. That wasn't something we really went over. And I think what's fundamentally inherent in advocacy across the various ways in which peer support specialists are doing advocacy is the notion of managing power differentials, both as a peer support specialist and also helping those they're working with managing the power issues that they're facing as they navigate services and providers. So this is an important part of advocacy. And of course, advocacy is well aligned with justice approaches and fostering access and equity to services.
So the next thing we kind of looked at was self-care. And the way that we've defined the thematic construct of self-care is as the practice of taking action to preserve or improve one's own well-being, particularly in times of stress. And this particular definition is a little bit expansive in the sense that what an individual may do in order to engage in self-care is going to be really distinct per each person. And so it's really about what works for you. Next slide, please. So this is a quote from a participant that was in one of our peer specialist training focus groups. And the quote is, "The self-disclosure and the sharing of lived experiences, also, may contribute in a different way from other mental health providers in terms of burnout and self-care." So really what this person is saying is this particular element of sharing about yourself and disclosing can lead to a different experience with burnout and positive and also challenging experiences with engaging in self-care. So that's really unique to peer specialists. Next slide, please. So under this theme, we had a couple of sub themes that really go along with it. So in relation to peer support training competencies that are a little bit more advanced, some of the topics that we could really explore further are coping skills, burnout prevention, compassion fatigue, boundaries, self-awareness, emotional regulation for yourself, and breathing skills, countertransference, and clearing. Clearing, I think another way to look at that is grounding, like a grounding exercise, something that helps you just feel a little bit more regulated within yourself. If you have any questions about the definitions of these sub-themes, or if you have any concerns with what this means, just hold your questions till the end and I would be happy to answer them. Next slide.
Okay, so the other theme that came up quite a bit is crisis support. So these definitions that we're providing is grounded in the data. So we decided to define what does crisis support look like in an advanced training course based on all the data sources that we just talked about. So advanced training and crisis support are competencies needed to skillfully respond to peers experiencing various crises, including suicidality, medical emergency, acute psychosis, personal stress or distress, exacerbation of mental health symptoms. And some of the skills specifically identified is de-escalation of those situations, suicide intervention, and support. So either sitting with folks who are experiencing suicidal ideations or providing more support beyond that. Basic CPR came up, which was interesting to me, and linkage to other emergency intervention services. Next slide, please. So some quotes here regarding crisis support, responding to suicide, suicidality, or ideation, or whatever term you want to use can be very much in the scope of practice for peer specialists. This is from a trainer. Another quote here, a lot of peer jobs are in crisis work. People are coming in with crisis. Mobile crisis teams require a peer. And so I think a huge need is in crisis. Another trainer here. So as you can see, there's a huge need to how do we support peers who are faced with peers who are in these high acute situations, and how do we also provide a linkage to support knowing when to do that. Next slide.
Okay, so the next theme we labeled, for lack of a better word, relational competencies. This isn't to say this is the end-all be-all word, but this was a really advanced training in relational competencies. Was described as involving a deeper commitment to learning how to enact mutuality, which is a complex emotional and interpersonal resource that requires the peer support specialist to regulate emotions, manage fluid boundaries moment by moment, which allows them to foster a safe place for shared experiences and emotional expression. Relational support is affective engagement, and as such, boundaries are inherently blurry and fluid, requiring the peer support specialist to continually find a sweet spot on the friendship to professional relationship continuum. Relationship competencies are trauma-informed as they are grounded in active listening, empathy, curiosity, compassion, and a non-judgmental attitude. So some might say this is sort of the crux of your work as a peer specialist, building that relationship, that collaborative, shared experience. I think it's fair to say that without that, it's hard to foster growth and hope and empowerment. I see there's a hand up and I'm not ignoring you. I'm wondering if you wouldn't mind holding off until we're end or putting it in the chat, and I'm happy to get to you. So some quotes to capture relational competencies. I think that if we're going to do an advanced, one of the most important things is to do a good refresher on mutuality, because that doesn't get done in the initial trainings. And it's the first thing to go when you get in behavioral health systems that are not mutual. It's a very hard thing to maintain and keep and operationalize every day. So really, what is it? What does it look like? How do you do it? Not just sort of being mutual, but really concretely, what is it? Another quote, but I think that's definitely an area for like more development in general and then more advanced training around, because you're asking people to provide these services to people and to be vulnerable, to be like a friend, but a professional at the same time. And so those roles are even more blurred. And then, it's just a lot. And I think the intern had the idea that she needed to fix the situation rapidly. I said, how can we do this different without re-traumatizing the guests? Because the active listening skills may not have been as deep as I would have liked them, to not re-traumatize a guest and to validate their emotions and so forth like that. But I think, again, sometimes they lack specific skills like trauma-informed care. So trauma-informed care, as many of you know, is its own skill set and curriculum. However, we decided that that is part and parcel of relational competencies, as is to some extent being cultural competent, because building a collaborative, shared, mutual relationship requires an ability to understand trauma and be trauma informed. It is an emotional experience on both ends. And so we really see relational competence as something that certainly one cannot learn in one course. And for many of us in the field of helping, it is a lifelong process.
Okay. Another theme that we found, which we called recovery support skills. So this is a set of skills that really helps with facilitate an individual's mental health recovery process. So as said in the slide here, advanced training and recovery support skills are skill sets that facilitates a peer's mental health recovery process. And skills include group facilitation, recovery planning and goal setting, and the application of recovery aligned toolkits. So the established toolkits and curriculum that is out there, including RAP, motivational interviewing, and seeking safety training. And group facilitation came up quite a bit in our data. So I think peers are asked to run groups, and they would like a lot more training in this area. Also, RAP came up and MI came up quite a bit. So just using, we just talked about relational competencies, using it to be, sit with someone and have a non-judgmental stance, rolling with resistance, not necessarily being the change agent behind it, but using some of the MI skills to be present with the peers. Also with MI, there's, we want to think about basic MI skills that we want to practice, right? Practice is always great. Doing role plays and those kinds of things. But there's also advanced motivational interviewing skills that could be taught. I just learned about this. There's a macro MI, motivational interviewing skills, that really addresses systemic oppression. And so that approach could be something that peers could be trained on to look at kind of the structural competence and socially produced trauma that could be experienced by the peers as well. Next slide. So here's some quotes here from a couple of peer specialists. One thing I would have loved if we could build on group facilitation. We have like a 2-day lecture on that in the entry course. We didn't have anything in the advanced course. And now in this internship and looking at like jobs, I realize how heavy group facilitation is. So this peer is speaking to feeling that they weren't quite ready for the amount of groups that they were asked to run. And then here's another quote here. Yeah, so I think as I've been working in the field like close to 12 years, I think that we can never get enough motivational interviewing training, because it's one of those things where you need to practice and role plays to really build the muscle memory. Next slide.
So our next theme, the definition's a little bit self-explanatory here, but it's supporting specific communities. And so, that's kind of what it is. It's providing peer support to people from very specific communities. Next slide, please. So this quote is also from a participant from one of our peer specialist trainer focus groups. And it says, I was thinking about like targeted populations. I feel like we address like working with communities of color, but also I'd be interested in training on supporting people experiencing like houselessness, people with disabilities, either physical or like neurodivergence and things like that. This next part of the quote I really like, and basically what they're saying is that they're really deliberate with their specific word choice. So what they are using is supporting, the word supporting, instead of the words working with or dealing with, in terms of talking about these particular populations. Next slide, please. So in supporting specific communities, we learned individuals were seeking advanced training around supporting these particular populations and a few others. So these communities range from mental health-based experiences, such as those navigating trauma, to identity-based, such as age, ethnicity, sexuality-related groups. There are also those with shared cultural experiences. For example, maybe people from rural communities. A lot of these groups, if not all of them, will experience crossover, and the individuals within these groups are really traversing their own various intersectionalities. So the following communities in particular really became prevalent in our study, and there's just a lot of mention of these particular groups. So we have older adults, which I'd say it's around like 60 plus, children, and then K is transitional aged youth. So it kind of varies a little bit, but typically it's going to be from like 16 to 25. How to work within family systems, LGBTQIA plus, individuals with disabilities, people who are having the experience of being unhoused, or those with chronic illness, people who have experienced or navigated their way through domestic violence or substance use, working with people that hear voices or justice involved and advocacy involved communities, people who have worked their way through trauma, eating disorders, are focused on harm reduction. There's neurodivergent communities, as I mentioned earlier, rural and BIPOC communities as well. For those that don't know, BIPOC is Black, Indigenous, and people of color communities. Next slide, please.
So advanced training in substance use and harm reduction can be defined as learning in more depth about co-occurring substance use and mental health difficulties. So that's when someone both has experiences of substance use and of mental health difficulties. Cultural differences between the mental health and substance use system. So we had a few participants point out that the systems themselves, the mental health and substance use systems themselves are very different. And depending on which system a peer might first receive services in, that might really shape their experience, and it's important to understand that. And then also navigating differences in lived experience. So for example, supporting a peer with substance use difficulties when you don't have lived experience of substance use, or vice versa, supporting a peer with mental health difficulties when you don't have lived experience of mental health difficulties, you have lived experience of substance use. Next slide. All right, so also within this category is harm reduction. Harm reduction is a non-judgmental, collaborative approach to reducing substance use and other behaviors that may cause harm, that focuses on reducing harm rather than requiring or expecting total abstinence. And then next slide. So here we have a quote from one of the trainers in our focus groups. Systems themselves have different cultures. Even the approaches to peer support on substance use and mental health are different. I think we've got to recognize the different cultures and help peer workers understand the different cultures so that they can see each other through a more cultural light. Next slide. All right, so we also had some additional findings that are relevant to share, but for various reasons are not advanced peer support training competencies. So the first finding is teaching modalities, which relates to class format rather than competencies. Many participants spoke about the importance of experiential learning through role plays, case scenarios, demonstration of skills, and experience in the field. Participants wanted to learn from each other's lived experience in the field as a peer support specialist and through interactive class activities like discussions. Participants also expressed pros and cons of different class formats like in-person, online, hybrid, and asynchronous classes. And they expressed a need for accessibility of classes, both in terms of disability and neurodivergence, and in terms of equitable access to enrollment. So reducing or eliminating financial barriers, making sure information about the class is available to peer support specialists with marginalized identities, etc. Some participants expressed a desire for clinical training, such as learning more about various diagnoses and learning clinical interventions for specific mental health conditions. We did not include this as an advanced training competency, as we do not believe that clinical approaches align with the peer support model. Finally, some participants expressed a desire for training to be a supervisor of peer support specialists. We did not include this in the competencies, as this is a specific training that may not be relevant to all participants in an advanced training. It seems best to offer supervisory training separately for those who are interested. And participants expressed a need for supervisory training that's aligned with the peer support model, as supervisors of peer specialists sometimes come from a clinical background and don't understand the peer support model. From participants, it sounded like more in-depth supervisory training is an important need in the field. And now I'm going to pass it over to Dr. Cronister to talk about professional development.
Thank you, Jace. Yeah, so professional development came up somewhat commonly as a theme. And, again, we didn't conceptualize this as an advanced training area. However, many participants did talk about needing additional training around, moving it into management roles. And this is well aligned with becoming a supervisor. Conducting program evaluation or program design. I think professional development also spoke to career lateral, moving up in your career, and also getting your first job as a peer support specialist. So it was a wide array. Some of it was like, we need some professional support around how to get a job and all the processes involved in that. And we also heard people who have been working want some additional training about vertical and lateral movement in their career, whether it's management or supervision. And certainly supervision and management roles, that is a controversial area in this field, because the question we're left with is, when you move into a different position, are you still a peer? And are you, in fact, following the principles and philosophies of a peer support specialist? So I think that wraps up our additional findings. I'm going to speak briefly to our limitations, and then we'll move forward and open up a dialogue for questions and discussion. This is a qualitative study, so we cannot generalize our findings. And we're describing findings. We're not making causal or relational inferences. As I mentioned earlier, a good chunk of our data came from a Qualtrics survey, which was significantly compromised by artificial intelligence. However, I think we did a very good job, particularly Jace and Mechila did a really good job of identifying the data that was through AI. All of our student focus groups are from one SF agency, and our trainers are from actually 4 states, not 3. I mentioned earlier, New York, California, Illinois, and South Carolina. Only one of our research team members is a certified peer support specialist. And the other thing is, we're all either counselor educators or counselors in training. And so we may have a clinical bias or a counseling bias. And finally, because this is our preliminary findings, we have not conducted a full audit of our findings, which we are planning to have 3 to 4 peer specialist trainers review our findings and give feedback to help us make some final decisions about our themes. Okay, on that note, we would love to have a discussion, hear your reactions, your thoughts about other training areas and future training directions.
It looks like peer manager's hand is up.
Yeah, hi, thank you. Terrific presentation. This is very informative and went into areas that I don't typically think of. But my question, so I represent a warm line that's very large in New York City. We handled over 20,000 calls a month. Have over 100 peer staff, and we do peer supportive counseling. And there was no real talk about when 2 peers get together and one of them is an employed peer and the other one is the person coming for help, what does that peer's skill set look like? In our organization, there's a lot of discussion about what techniques should be available to the peers and what should they be trained on. But we do regularly train on the Socratic method and kind of a version of CBT, which we call narrative reframing. And so we do have some techniques that we use in the idea, and we also base it off the RAP plan, like discuss how to live with, how to mitigate your kind of reactions to your triggers, by asking questions about, what could you do if when this happened at the beginning, you know? So I'm just wondering, I'm wondering why I didn't hear about supportive counseling and what you think about what should be in that arena.
Thank you. I'm happy to take a stab at it. I'm guessing you're at NYC Well, is that
Yep.
right? Okay,
Yeah.
cool. I used to work at the warm line at the Mental Health Association of San Francisco, so we referred to you all the time. Yeah, I think you're asking a really great question. And I know in my roles as a peer support specialist, this was something that came up a lot in terms of like what, interventions, to use a clinical term, or what approaches can we use to people who are, coming to us with different challenges. And I know that that's something that I had a lot of conversations with a supervisor about, just because it can be hard to find that boundary between like what is peer support, so what is very like mutuality focused, like non-directive, meaning like not telling someone what to do, and also non-therapeutic, versus what can we do, and so some of the things that we did have, that came up in our study were approaches like like motivational interviewing, wellness recovery action plans, though I guess that would be kind of hard to do on a warm line, and seeking safety, in general, just working with a peer on using their own like self-knowledge and things. But yeah, that's a great question, and I don't think we have a complete answer because I think that's something that the peer support field is kind of still struggling with.
Yeah, I agree. Okay, thank you.
Thank you. Anissa?
Great, thank you. So when you were talking about the demographics, you said that most peers were saying that there was a 3.9 on the Likert type scale in satisfaction with peer supervision. So I'm just wondering, in what settings were the peers working? Were they being supervised by peers? And just as follow-up, in competencies and in terms of, like trauma competency, cultural competency, well, not competency, but responsiveness, and supervision.
Happy to take that question. Just to respond to the question about supervision. I don't have the list of where everyone was working. The majority of our participants, I would say, were in, really an array of settings, whether there were wellness centers or community mental health centers, hospitals, very specific peer support run agencies. But I will say I meant to include this data around supervisors. About 40% of the supervisors were certified peer specialists. And many of them were certified peer specialists and, say, a social worker, or an allied medical provider, or a counselor. But still 40%, one might say that's a lot lower than we'd like. If we aspire to have all of our supervisors be certified peer support specialists. So I hope that I'm not sure if you had answered that question as well. And then you had another question about competencies. Trauma.
Yeah, trauma, cultural responsiveness. And then just in terms of, I think in order to stay aligned with the social, that peer support was born out of the disability and civil rights movement. So the social justice aspect of it is to keep peers in a progressive career ladder as peers, so that peers don't have to feel that they necessarily need to go to social work or to counseling to make more money and move up when they're in clinical settings or things like that. Because in a peer-run organization that I have worked in, that there isn't a lot of money to go around and the cost of living is expensive. So to stay true to that, peer supervision and more advanced trainings, and collaboration with higher education institutions so that peers can get those kinds of things. So like competencies like supervision and things like that, so that peers can stay true to the grassroots and social justice movements that they it was born out of, yet be able to make a living wage and move up in their career.
Yeah, I really appreciate those comments and just the justice approach. And, I can't emphasize enough how, much, at least I think from our perspective, that, particularly the disability justice perspective of this movement needs to be led by those who are part of and receiving the services. And so we are well aware that a lot of supervisors or people in the healthcare field are just coming back to get certified and are not trained as peer specialists, right? And so this is an important issue when we think about fidelity to the peer support philosophy and principle, is who are providing these services. And are we in fact ensuring access to these individuals and prioritizing training for these individuals and supporting their work as supervisors and managers, if in fact, and also, something to think about around that is, what is a model of supervision or management or whatever you want to call it through a lens of peer support versus supervision, how we traditionally teach it, right? And so, I know some of this is growing pains of a profession, but these are really important things to think about if we're going to continue to move forward through a justice lens, right? And to, sorry, I think we probably need to move along with questions, but I really appreciate your comment, and I hope that you feel heard. Let's see. Sybil, am I pronouncing your name correctly? I apologize. Sybil?
It's Shabelle, like a bale of hay, Shabelle.
Okay, Sybil.
I'm really appreciating so much of this. And I'll try to be cohesive in the comments that I have to offer. I very much relate to putting value on an advanced competency in peer support being relating with other professionals that we interact with as peer support workers. And sort of as an example of that, I work in a peer-run organization who at this moment has an interim executive director who is hired from a consulting firm that provides interim leadership for nonprofit organizations. And they came to the position with no experience ever in peer support. So they had a very different, initial background and experience that they then had to kind of alter and fiddle with to be able to interact with us in our natural habitat, if you will. And that has been a real struggle. More recently, from my own experience, on a positive note, I had the good fortune to be able to be in the same. Well, it was good fortune that we were in the same room. It wasn't great fortune that we had to be there, but I was in an ER room supporting a person. And also there were two advocates from a local violence prevention center and a sexual assault nurse examiner. And to be able to have all of us in the room at the same time with the person we're serving was really potent. And I wish I could have stayed, and I needed to leave, but a definite props to that being on the list of really valuable competencies in advanced peer support. So I have other things, but I'll let somebody else go for now.
Thank you so much for sharing. That's really helpful for us to hear. Anyone else have questions or comments?
Is it Shabelle? Did I say that right? Okay, since I'm not seeing other questions so far, you said you had a few other things you wanted to talk about?
Yes, I'm wondering, as you're looking at the model of peer support, I just completed my bachelor's in psychology, and the capstone of that was doing a huge literature review on peer support. Yes, at 55, I finally freaking landed that piece of paper. It was huge. And one of the things that I felt was a motivator to that was to include mention of intentional peer support as a model of peer support to put forward as something that was more comprehensive and, you know, was a good homing beacon for peer support workers in general. What I don't know is how widespread that is used as kind of a template for all the things you guys are building in all your different organizations. Is intentional peer support the core training? If not, what is it?
That is a great question. I obviously am not knowledgeable about all the peer organizations, but yeah, I do know that intentional peer support is a great model, and it doesn't seem that everyone uses it. It seems like it's sort of one of multiple different approaches that people take when training people in peer support. But I agree that it's a great model, and it would be great to have more training on it.
I could go on.
I have a feeling that this presentation ends at 11:45.
Yes.
However,
Oh, you're right.
I am happy to hang around until our whoever is managing this hops on and field comments or questions.
The next presentation is in 12:30 until 12:30, so there's a half-hour break, so you can continue really up
Okay, great.
12:20 if you'd like.
Yeah.
Yes.
Well, I'd like to also respond to some of those comments in the sense that, you know, I think an important piece of information that we uncovered here and heard a lot about is, as you were talking about working in a more integrated setting with interdisciplinary and being a member of this team, which from what I hear from you felt really, really good. I would also just add that peer support specialists are very needed in our health and mental health field. I mean, we have a health and mental health crisis around providers. And so it is likely that more and more peer support specialists are going to be in a much wider array of settings. And I think aligned with that is making sure that our peer specialists have the tools they need to stand firm with, I'm here from a particular philosophy and lens, right? I am not here to slide in as another medical provider. I am here to provide another perspective and to think about a client, peer, patient, whatever they're called in that context through the lens of peer support and recovery, which I think is particularly hard given the entrenched medical model that we all exist in, right? And so it is an important area of advocacy, skills, communication, whatever you want to call it. The other side of it is that we need to educate our employers, which I know in California, there has been guidelines set forth to say, if you're an employer of peer support providers, please read this. Nonetheless, we all know that those books often get, laid under the table. But there are efforts and intentions to say, please, employers, understand this philosophy. You're not hiring a peer support professional to do diagnosis. And quite frankly, a lot of the clinical interventions, CBT and motivational interviewing, while they can be helpful, they don't necessarily align with a peer support model.
Yes. I've kind of been on both ends of that. Like the situation I was just describing, I am a respite coordinator for a peer-led organization, which includes a residential program. And so I was in the room as the person who was going to be providing respite for the individual we were supporting, and I was providing her transportation and support. And then there were these folks who were advocacies for violence prevention, who were much stronger in the advocacy. Let's rattle the right chains to get the paperwork done and get things handled on the logistical end. And then we have a medical care provider as the SANE nurse. And it just, I found that to be great. What I also mentioned, actually, even in the last session, is that I have some great trepidation about this movement of peer support workers into clinical environments and how it can impact the fidelity to a peer support model in peer support workers being able to actually be in that mode when they're in a paradigm that doesn't support that. And sort of the inherent struggles of trying to transplant ourselves into places that are not fertile, for what we do, and how we can support ourselves in being able to do that. And that supervisory training that was described in the first session I went to is, I think, really key for that, in making the two go together sort of well. Anyhow.
Looks like we have another hand, but I did want to speak to that. I think we were focused on peer support competencies, but I think we also need to train other folks that we are in community with in terms of service providers, right? So we try to bring some of the peer support model and lens to our clinical training program here at San Francisco, but I think this needs to be done across different clinical medical settings where peer supports are being provided. So it's a larger systemic issue, and I appreciate you bringing that up. I wonder if Priscilla, you have a question? Oh, I'm sorry.
Yes, I do have a question. Thank you for sharing this wonderful data and information you gathered. I'd like to get maybe a step out perspective from the work that you're doing. And I understand the next step is to do an audit of your data. What's the ultimate outcome from this? Is this going to be data presented to the legislature? What is that? What is the ultimate intent from conducting this research?
Yeah, I can take that just initially, and thank you for that question, because we are always asking ourselves, those of us who do research, what is the point of this and what is its impact? I will say this was initially a study that we were invited to do by a peer support training program that in fact was kind of tossing and turning about this. Like, we're kind of offering this, but we're not sure what to provide. It's sort of in the air. People are talking about it. There's sort of fragmented advanced courses, whether it's workshops, and now there's a discussion about supervision, and now there are these specializations. So, what do we do with all this? And how do we continue to train our peer specialists? And again, I go back to, like any profession that's in its beginning and its growing pains, there are sort of these periods and should be ongoing, like figuring out what are the roles and functions of those in this profession. And it should actually be a lifelong exploration in any discipline and profession. And so in that respect, I would say, first and foremost is to communicate our findings with our providers. Does this align with what you all are doing, and how does it fit? I mean, one of the things that, many of the providers in California, they're providing many different iterations of training. Some are 2 days, some are 6 weeks, some are online, some are offline, some are providing specializations, and so how does, we want to bring forward what we found that has some scientific foundation and say, consider this in your training. So I think that's one thing, but I think secondly, this is a qualitative study, right? And so this is not, we do need to gather more information, validate our findings. I think there have been what we call fidelity measures in the field of peer support to sort of say, okay, is your organization doing this, this, and this, right? So sorry, I'm talking too much. Oh, I'm sorry. Bye, Shella. I wasn't sure what the waving was going on. Shella had to leave, I think. So, I think, in a perfect world, we figure out what are the most important things that peer specialists need to learn in order to be, doing their work in the community. What do community providers need, right? So this ongoing dialogue about what do we hear from peer support specialists? What do we hear from trainers? Oh, I'm sorry, I'm all over that. One other thing that we really need to do is we need to ask those who are employing peer support specialists. That's sort of the third leg of this, I think, of like, what is your perception of what a peer support specialist be doing? Because if things aren't aligned, then it gets confusing, and we know they're not. We know there's a lot of misalignment between non-peer run agencies that employ peer support specialists, and what their expectations are. And so, impact is to provide information to agencies. Larger impact is to continually examine roles and functions, gather information from community providers who are employing peer supports and those providing the services to say, hey, are you getting the training you need to work in the field? And do those who are employing you feel like you have the training that you need? So I hope that begins to answer your question.
Yes, it does. It sounds like a training effectiveness assessment, right? Looks like an ongoing assessment. So yeah, that's helpful. Thank you. Is that's all I need to know. Thank you.
Thanks for the question.
Yeah.
I had a question. What inspired you guys to do this?
I don't mean to be the one that talks all, but we were invited by a peer support training agency in our community to look at this. So this was a starting point, and it's really refreshing to conduct research that is needed by our community versus driven by our needs as academics. So, and we had worked with this agency in different capacities, and they do amazing work. And we sort of did the research leg of this. I hope that helps. And we're also, speaking for myself, I am very, very committed to the growth and integration of peer support specialists into our larger healthcare field.
The bail?
Hello again. I wanted to just go over one piece that I just found incredibly accurate that you were describing. I forget exactly where the exact words, but you're describing how peers without another peer kind of don't exist, and that peer support is based on it being a relational frame, and that explains so much about what peer support is about. When you can say things like that to somebody who hasn't ever heard of what peer support is, I find that to be an incredibly useful way of describing it that gives them so much more information than like the language we use all the time about mutuality and this and that. You know, they're like, huh? What's all that? But when you talk about like, well, I really wouldn't have a job to do unless I was interacting with another person. And I think that says a lot. That's all I wanted to say.
Thank you. Yeah. And I mean, speaking as a peer support specialist as well, I think had kind of an aha moment when that trainer shared that framework, because I think it's very, very helpful framework.
All right, I gotta go. Thank you all.
Thank you for being here, for your
Thank
great
you.
questions.
Yeah, thank you so much, everyone. We really appreciate you being here. And all of our contact information was shared in the chat, so please do feel free to reach out. And we will be sharing our slides as well with Share. So hopefully you'll get access to them in some way as well.
Yeah, I hope everyone has a great rest of your conference day. And thank you so much for joining us. It's been a pleasure having this discussion. And again, please don't hesitate to reach out. If you can't find our emails, Dr. Fitzgerald and I are certainly on the San Francisco State Department of Counseling website, but they are in the chat.
Thank you. Bye-bye.
Thank you so much.